we're going to go ahead and get started. So we're up to week 5. Goes fast, doesn't it? Goes really fast. Okay, so this week's all about the newborn. We're finally there. The baby's here. So we're going to get right into it since we've only got about 30 minutes. So let's start off with transition. That's the baby's first foray into the extrauterine environment. So once the cord is cut and the infant takes their first breath, that's when transition begins. So transition simply means that they are transitioning, quote unquote, from the intrauterine environment to the extrauterine environment. So when the baby, if you think back to what we talked about during the pregnancy, throughout the pregnancy, the placenta pretty much did all the work for the baby, supplied the oxygenation, exchanged gases, eliminated waste products, provided nutrition. It basically did everything for the baby. But now that the baby is here, now the baby needs to transition and is going to be responsible for all of those things themselves. All right, so here we go. First breath. There are chemical factors that trigger the baby to take their first breath. Hypercarbia, so they have a lot of carbon dioxide built up in there. Acidosis, because the lungs are pretty much inert while the baby is in utero. They're really not functioning. They're certainly not doing what they need to be doing once the baby is born. And then there's hypoxia. So the very, very, very low oxygen level. So generally, when the baby is first born, they're going to look blue until they take that nice, deep, big first breath. Then there are thermal factors. You know, the cooler environment, you know, when they were inside, they're nice and warm because they have mom's ambient temperature to keep them warm. Plus, they had all that amniotic fluid to help maintain their temperature while they were in utero. But once they come out, well, they don't have that anymore. So it's generally a very cool environment compared to where they were, and that triggers them to take that first breath. And then there's mechanical factors, the removal of fluid from the lungs. So while the baby, if the baby is born vaginally, while they are coming through the birth canal, they get that squeeze upon entry into their outside environment, and that squeeze helps to remove some of the fluid. Plus, we go at them most of the time. Once the head is delivered, the providers are going to take a bulb syringe and they're going to be suctioning out their mouth and probably their nose as well to kind of help to clear some of those secretions. So those 3 different factors contribute to signaling baby, it's time to take your first breath. You're here. Now you got some work to do. Okay? Any questions on any of that so far? Does that make sense for everybody? Not seeing any. Okay. If you do, feel free to just shout them out. Kristen, you had a question? No. Oh, okay. Just making sure. I didn't want to blow past it if you did actually have a question. Okay. So something very important that I wanted to touch on. Again, I only have a little bit of time today, so I'm just trying to hit the high points of all 3 of those chapters that you guys had for this week. So cold stress is something that if you're a nurse taking care of the newborn infant, you definitely need to be aware of how that works and what potential complications can happen. So one problem with cold stress is increase in your oxygen, in the baby's oxygen consumption. Babies are going to be breathing faster. They may struggle more with breathing. They're working harder. And the whole thing is to try to increase their metabolism to try to produce heat. Okay, that's, you know, the baby only has one way of producing heat, really, and that is to increase their metabolism. And that will then increase their oxygen consumption. So that's a problem. Non-shivering thermogenesis is the process that the baby will go through to try to produce heat. Okay. They have very limited body fat, so there's not a lot of that to use either. And the adipose tissue, the brown adipose tissue, is what they use to create the heat. But when they break that down, now they have all these acids floating around. So they can actually end up in a metabolic acidosis if it's left untreated. Okay. Limited ability to shiver. Newborns generally don't shiver. They can, but they generally don't. Skin is very thin, and blood vessels are close to the surface. So that's something to be aware of. You know, their skin is pretty thin. So here's some signs and symptoms you can see on my screen here on the PowerPoint. Skin is cool to the touch. They may have some mottling happening. Okay. Central cyanosis, that's a concern. Central cyanosis, a cyanosis of their trunk, maybe even some circumoral cyanosis around their mouth you might see. Decreased responsiveness. Remember, they're getting acidotic and they're hypoxic. So they're not going to be as responsive as they normally would be. They may even be jittery because of all those acids running around. Plus, they've used up all their metabolic stores, so they may even have low blood sugar or hypoglycemia. And they're very tachypnic. They're breathing very fast. So this is not a good thing. This is something that, again, if you're going to be working with newborns, you have to be aware of this problem because we need to intervene as quickly as possible to get baby warm. Now, some of the things that we can do is obviously we can wrap them more, maybe double wrap them, make sure that they have a t-shirt on, make sure they have a hat on. Babies' largest surface area is their head, so always making sure that they have a hat on. Instructing the parents to make sure that the baby always has a hat on, and making sure that they have enough blankets around them. That way. You can do skin to skin with mom. You can have baby lay on mom's chest or dad, either one. Either one is good for skin to skin. Have them go skin to skin and keep them that way for a little while. That'll generally help to increase their temperature. Make sure that you have the temperature in the room warm because, we lose our heat when we're in a cold environment. So make sure that the room is nice and warm. If you've tried certain things and it's not working, or if baby is showing you signs of not being stable, in other words, having decrease in responsiveness or central cyanosis, you have to put that baby on the radiant warmer. Okay, skin to skin is not going to be enough. So you've got to put the baby on the radiant warmer. You may even have to attach the skin probe at this point to try to get baby's temperature regulated. Because once they're having decreased responsiveness and they're starting to show signs of hypoxia, that's a problem. And babies can go downhill really quickly, especially newborn babies. They don't have a lot of reserve, so they don't recover as quickly. So we need to intervene fast in order to fix this problem as quickly as possible. Okay. Any questions on cold stress? Make sure that you review this because this is going to be something you're going to need to know. So make sure that you take some time to review cold stress. Okay. All right. So next up, normal newborn. That's chapter 18. I'm going to go through some very specific concepts out of that chapter. So immediate newborn assessment. So APGAR is something that we do in order to establish whether or not baby needs our help in any way. If baby is crying and they're moving around, they're moving their arms, they're moving their legs, they're breathing okay, they're pinking up nice, their heart rate is good, then that tells us that everything seems to be going along just fine and that baby doesn't need anything extra. But on the other hand, if baby is born and having not really as active as we would like them to be, not really crying or not crying very actively, not moving their arms, their legs very much, maybe their heart rate is low, that indicates to us that baby needs a little more help. So we have a grading system that we utilize called APGAR scores. So there are 5 different categories. Each category is worth 2 points. So baby can have the most 10 points on the APGAR. We like the first APGAR score that we do is at 1 minute, and we would like that APGAR score to be greater than 7. But if it's not, if it's less than 7, let's say 5 to 7 range, we're not too concerned. But if it's less than 5, then yes, we would definitely be concerned. We would definitely be doing more to help baby than what we normally would be. Okay. The 1-minute APGAR tells us how baby tolerated labor. How did baby tolerate that labor process? That's what the 1-minute APGAR tells us. Now, if you've had a labor where baby had a lot of decels happening, that means that baby was hypoxic. So when baby is born, they could be having some issues right away. They may need a little more help. Okay. Or if you had a situation where you had to have an emergency C-section for some reason because baby had decels or something else happened, maybe you had a cord prolapse or whatever the case may be, then that indicates to us that baby might be needing a little bit more help after birth. So that is part of the initial immediate newborn assessment. Okay. We expect babies to be crying. We expect them to pinken up real nice. We expect them to, their heart rates to be above, 100. We'd like them to be above 100. If it's less than 60, then you're going to be doing chest compressions automatically. You automatically are doing chest compressions. Warming, drying, stimulating. This is part of initiating that breathing. So after baby comes out, you are warming it, you are drying them off, and you're vigorous. You're not just, patting them very gently. No, you're being pretty vigorous with the drying. And that in part stimulates them. If you notice that they're having issues with their airway, you got to clear that out. You always do the mouth first because they don't really use their nose. So you're doing the mouth first, then the nose. So you may have to suction that. And then the APGAR scoring. And then you're looking at the physiologic adaptation. So now we've done the 1 minute. Let's say we had a 5. Okay, so our antennae have gone up, and now we know that we want to keep an eye on baby. Which categories is it that were low? Was it the activity? Not a lot of activity. Was it the pulse? That definitely would be a concern. Grimacing. So, is baby, their face not scrunching up? Because they usually are pretty mad when they're born. They don't really like being in this cold, bright room, okay? Or what is their appearance? What's their color looking like? Is their color not good? Or what's their respiratory rate? So which category is it that's low? That's the one that needs surveillance, okay? Now we've come up to the next time we take the APGAR is at 5 minutes. Now at 5 minutes, that score we definitely want to be greater than 7. If it is less than 7, baby needs to be surveilled. If they haven't improved at all, then they need to be surveilled. And they may even need more monitoring than what a normal baby would need. Okay? They may actually need cardiopulmonary monitoring. Maybe a trip to the NICU. We'd have to see. But the 5-minute APGAR is telling us how baby is adapting to the extrauterine environment. How is baby doing outside? That's what the 5-minute APGAR is telling us. Are their lungs functioning okay? Is the heart functioning okay? Are they, what does their skin color look like? What does their activity look like? Is their neurostatus okay? That's what the 5-minute APGAR is telling us. Okay. So I posted a handout under Module 5 about specific to APGAR scores. So take a look at that if you have any questions about APGAR scores. Take a look at that, refer to that. If after you've had a chance to review that, you're still not sure, please feel free to reach out to me and let me know. Okay. Any questions so far before I move on? And the APGAR score generally is something that the nurse does. We usually do the APGAR scores. Okay, I'm moving on. The next thing that I wanted to just touch on was safety for the newborn. It's very, very important. So making sure that the ID bands are on after we've stabilized baby, throwing those ID bands on immediately. There is going to be 3. So 1 for baby, 1 for mom, and then 1 for whomever mom designates is the 3rd person. So if it's the dad, great. If it's the significant other or partner for mom, then that's the person that gets the ID band. Whoever she designates for the 3rd ID band is the one who's going to get it. And that provides safety because there's a very specific number attached to that band. And nobody that does not have one of those bands gets that baby. Absolutely nobody. Even if grandparents were to come and say, oh, well, I'm such and such's grandpa, and I want to take the baby, to the room or whatever the case may be. You are not allowed, absolutely not allowed, to give them that baby. Okay, they have to have the ID band on. There are some facilities out there. The facility where I had my kids is one that I can get as an example, where nobody even comes to visit unless they have the ID band. So there are some facilities that are very strict about who comes to visit, who gets access to the floor. And this is why, because we need to make sure that mom and baby are safe. Okay. Hugs tags. It's a brand name. There's also another brand name called Halo tags, but Hugs tags and Halo tags, they provide electronic surveillance for baby. Some of them are placed on the ankle, around the ankle, and some can actually be attached to the umbilical cord clamp. So it just depends on what type your facility has, but basically what it is it's a locked unit, right? You only have badge in, badge out access, or you have to be let in by the HUC or by whoever's at the desk. So if the baby gets within 3 feet of those locked doors, an alarm will sound. And when that alarm sounds, then it's all hands on deck trying to figure out where this particular baby is, because each of those tags has a serial number that is inputted into the computer, and it is attached to that baby. So until that baby is found, nobody gets in or out of that unit. It's completely locked down. So that also provides a measure of safety. We also instruct the family not to carry the baby around. Keep the baby in the bassinet. Unless you're in bed or in the chair, holding baby, feeding baby, changing baby, whatever the case may be. But you shouldn't be walking around with baby in the room, okay? Because you could slip, you could fall. If mom were to have a dizzy spell all of a sudden, she could slip, she could fall. It's all for safety of baby. So we do educate to make sure that they keep the baby in the bassinet unless they are handling baby for some reason, that they're changing baby or that they're feeding baby, but they need to be sitting down. They need to either be in the chair or in the bed. They shouldn't be standing around with baby because it's not safe. Okay. The other thing we do for safety, I didn't have it on here, but I'm just going to mention it. We instruct the family about the name tags of the employees. You tell them their name tag needs to look exactly like mine. If they don't have a name tag that looks exactly like mine, they are not allowed to take baby at all. You do not let them take baby. That's why we do rooming in. That's one of the big reasons why, is to avoid infant abduction, to prevent infant abduction. Okay. Anybody can get a uniform. They just have to find out what the uniforms look like on the unit, and they can go to Walmart and buy a uniform. Okay, that doesn't mean anything. But the name tags, that's something that they can't just get anywhere. And a lot of facilities have special plaques that they put on the back of the ID band or tag that indicates what their role is: RN, PCT, CNA, HUC, whatever the case may be. And they're usually a special color for that unit. The unit that I worked on, it was orange. The little plastic piece that went on behind your name badge was yellow, or orange, sorry. So all of these things just to keep baby safe. And we are educating the family about all these different pieces that we have in place to keep baby safe. And it also is to keep mom safe as well. Now, most of you know that the nurseries really don't exist anymore. They've pretty much been phased out of pretty much every facility. I don't know of anywhere near here that have an actual functioning nursery. Rooming in is considered best practice now. And that's where the baby never leaves mom's presence for any reason other than medical necessity. So what would be medical necessity? Well, if you had a boy baby who needed a circumcision and the parents wanted him to have a circumcision, that could not be done in the room. That is something that the baby would have to go to a different place to have that done. And they normally have a room designated for those medical procedures. It's not technically called the nursery. It's more like a medical procedure room. is basically what they call it. Then if baby were not stable, something was going on with baby that you were just concerned about baby, then you could take baby to that room. There's generally going to be a warmer in there. There's generally going to be some cardiopulmonary monitoring stuff set up in there that you could hook baby up to for monitoring. But those would be the only reasons that baby would leave the room, because for just general labs, lab draws, baby does not have to leave the room for that. You can do that in the presence of the parents. The baby doesn't have to leave for that for any reason. If mom were going to take a shower and she did not have a significant other with her, we would want her to alert us and let us know, because we wouldn't want baby to be in the room alone, unsupervised. So in that case, we would make some sort of arrangements for somebody to be monitoring baby in the nurse's station while mom is taking her shower. And then she just puts the call light on when she's done and we bring baby back. So those, so very limited reasons why baby would leave the room. Okay. Any questions on baby safety? It's very important. Okay. All right, so last thing I'm going to cover today is high-risk newborn. So that's chapter 19. There's many different reasons why a newborn baby would need monitoring. As I said, when I was talking about the transition, if they had a difficult labor, if baby had issues during the labor, maybe a lot of decels, maybe they had a cord prolapse, maybe mom had an abruption, there was some sort of situation that baby is not stable after birth, they would need monitoring. Now, not every hospital has monitoring for newborns. What you would have to do in that case is to stabilize baby the best you can and then arrange for baby to get transferred to where they would have monitoring for baby. So neonatal intensive care units are very high tech, and they're for monitoring our most vulnerable newborns. So some of the kiddos that may be in there, I've listed here. So premature infants, those that are born before 37 completed weeks of gestation, would definitely need to be in a NICU type environment. Now there's different levels. There is the level 3, which takes the micro preemies, the babies that are like 23, 24 weeks, really, really small in size, really, really early. A level 3 NICU would then take care of them. But then there's also a level 2 NICU, which in some cases is called a special care nursery. It's not necessarily called a NICU. It's called a special care nursery. So that NICU or that special care nursery would take care of babies that are, let's say, 30 weeks and up. Okay, so it just depends on what the hospital's designation is as to what kind of facilities they would be able to offer to these types of babies. Really small community hospitals probably not going to have much for these types of babies. They would require too much monitoring. Some other considerations: weight, the size of the baby matters, and it goes to both ends of the spectrum. Really large babies, large for gestational age babies, they need to be monitored at least for that first 24 hours. And again, sometimes a premature baby that is born before 37 weeks can be large, can still be large. So this doesn't mean that it's a term baby, because premature babies can be large if they have a diabetic mother. Okay, small for gestational age babies also might need to be monitored for blood sugar. Both of these babies, large or small, would need to be monitored for their blood sugar. If you have a large for gestational age baby born to a diabetic mother, the risk for hypoglycemia is very, very huge. Okay, they may have issues maintaining their blood sugar, especially in that first 24 hours. Okay. Small for gestational age babies can also have that same problem where they're having issues maintaining their blood sugars, but they can also have issues maintaining their temperature because they're small. Okay. Next up, genetic complications. So if you have a baby that is born with some sort of congenital defect of some sort, they may need to be monitored as well. Okay, now a baby that is born with trisomy 21 or Down syndrome may or may not need to be monitored. It really depends how baby is doing. Those babies aren't always automatically monitored. It really depends. Sometimes those babies can be born with heart defects. If they have heart defects, they may need to be monitored at least for the first 24, 48 hours, depending if they can, because then they're going to want to get some testing done, like an echocardiogram or something like that. Okay. But some other congenital defects, if they had cerebral palsy, they probably would need to be monitored. Okay. Or if they had some other significant problem, they may need to be monitored. Okay. All right. So hyperbilirubinemia, sometimes those babies would need to be monitored. Now, you're not always going to see that initially after birth, but within 24 hours, they may develop it. If they had a traumatic birth and they have a lot of bruising on their face or something, or if they had a precipitous delivery and they have a lot of birth trauma, a lot of bruising to their face, they may end up with hyperbilirubinemia and they may need to be monitored. Okay. Babies that have apneic episodes, that they stop breathing, they need to be monitored. Babies that are having difficulty with feedings, that are vomiting a lot and they're just not tolerating their feedings, they would need to be monitored. Remember, they're very vulnerable. These guys don't have any reserve. So, there's several different reasons why these kind of babies would need to be monitored. So it would be important to note whether or not the facility that you're working at has the capability of monitoring these really little babies. And remember, NICUs have been around a long time. They've actually been around since the 70s. I don't know if any of you are aware of that, but they have. They've been around a really long time. I remember reading an article a number of years ago about a group of people, I think there were 3 of them, that were born at 23 weeks back in 73 or 74. And they were in the NICU even back then. So the technology has certainly advanced, but the capability of monitoring has always been there for many, many years. Many years. I worked with lots of nurses that started out when NICUs were new. Okay, any questions over anything I covered today, guys? Okay, well, thank you. Thank you too, Jennifer. Thank you guys for coming.
Hey, I just had a question about remediation for the practice test. Do we remediate both A and B practice assessments? Okay.
If you had less than 100%, if you have 100% for the practice assessments, you don't have to do remediation because there wouldn't be any topics to review. Only if you're less than 100%.
Okay, thank you.
Oh, you're welcome.
I'm sorry. So we're remediating on A, B, and the proctored?
Yes.
Okay. Thank you.
And are we turning them all in at the same time next week, or how is that working?
So
for the one.
hold on. Let me stop this here real quick.